Hello, my name is Gary Morgan from the Trust Comms team. I'm really pleased to be joined by Natasha Bryant, who's our suicide prevention lead, and we'll talk a little bit about what that means shortly. It's obviously Suicide Prevention Day, so we're keen to talk about the issues around suicide and the work that the Trust is doing. So without any further ado, I'll introduce Natasha, and Natasha, perhaps you can just explain a little bit about how you become a suicide prevention lead and what that entails.
Yeah, sure, Gary. It's been a very interesting and rewarding journey over around the last 20 years. So in around 2005, when my children were quite little, I was doing some voluntary work, therapeutic work in gardening, so getting involved in community allotments and working with people with mental health problems. This opened my eyes up to a whole new world of mental health, and very much wanted to do more and help more. Having worked with people. So in 2007, that's when I first joined AWP jointly as a healthcare assistant, so working on the inpatient wards around the trust. And I also started to undertake my mental health nurse training, and as part of that doing a degree at university. So I qualified as a mental health nurse in 2010, and I've been working with AWP ever since. So for the last 15 years I've been working as a registered mental health nurse. The first 5 years of that I spent as a care coordinator, so working in the community mental health teams, and I often worked with people that were at high risk of suicide or significant self-harm, and that was a really interesting and rewarding experience as well. And I did an awful lot of learning in those first few years. And I think reflecting on what I learned, I think mainly it was around the importance of relationships, building relationships with people, therapeutic, trusting relationships, focusing on engagement and being really trauma informed in those efforts, recognising that people may have trauma backgrounds. And so we need to be really proactive in our efforts to engage people. After that, so in around 2015, I moved into mental health crisis services across AWP, where I started as a registered nurse, moved into the senior practitioner role, and then took on the team management of the crisis team. Very much retained a clinical focus in that work. That's something I've always been very passionate about, is retaining that clinical focus. And in around 2018, I moved into a quality improvement role. So that was supporting the clinical lead to embed learning from serious incident investigations and making sure that we were learning from where things went wrong. Following that, so in around 2020, right at the start of the pandemic, it was actually during the first lockdown that I moved into mental health liaison services, so providing mental health assessments into A&E departments during the pandemic, which was obviously quite a challenging time for obvious reasons. Following that, I moved up into service managing crisis teams and mental health liaison, working across Swindon and Wiltshire mainly. And then I saw the job advertised for the suicide prevention lead, and I was reflecting on this again earlier this morning. And what really strikes me is that often when we have big events across the world, people will say things like, I remember where I was when that happened, or when I heard that news. I remember where I was when I saw the suicide prevention lead role advertised, and just seeing it invoked quite a emotional reaction, and I felt very much compelled to put myself forward for that role. Throughout the years in practice, sadly, I have experienced personal loss, so suicides of friends and family members, supporting people that have been bereaved in my social circles from suicide. And so very much wanted to take that role forward, and I was successful in obtaining that post and started in the role as suicide prevention lead just about 3 years ago now.
Was it a new role for AWP, and if so, or even if it wasn't really, how has it evolved over the last 2 or 3 years?
So we have previously had a suicide prevention lead in post who was absolutely fantastic, and I remember working with them when I was a much more newly qualified nurse and having great respect for the work that they did. So it felt quite an honour to be in that role. And one of the first things that we did was think about the strategy for suicide prevention, and it was quite a shift for somebody like me who was very used to having one-to-one conversations with people who were struggling with suicidality, with poor mental health, to move into that more strategic role. So thinking about the universal suicide prevention strategy and techniques that we can employ that will have the most impact. There's an awful lot of evidence and research and literature and data emerging around suicide and suicide prevention, and very much see my role as kind of taking all that in and then being able to translate that and share that to our clinical staff on the front line, so people feel up to date and well equipped to do the really difficult jobs that they do.
That's great, thank you. Now, we said at the start, it's Suicide Prevention Day this week, so it's an opportunity to really, I guess, shine a light and give a focus to suicide prevention. I think the theme is changing the narrative this year. What do you think that is? What does that mean to you?
I'm really passionate about language. This is a really particular area of passion for me. And I think that some of the traditional language around suicide and suicide prevention can and has contributed to shame around suicide and suicidal feelings, silence, misunderstanding. So phrases like commit suicide, for example, quite a widely used phrase, comes from a time where suicide was a crime, and that has been changed since, I believe, the early 1960s. And so we will encourage people to use phrases like die by suicide, or somebody taking their own life, to try and take that judgment away. And equally saying things like a successful suicide attempt or an unsuccessful suicide attempt, equally quite harmful language, in that they frame a death by suicide potentially as something positive. And so what we would encourage people to say is use language like somebody survived a suicide attempt. It takes great strength to work through suicidal feelings, to ask for help, and to come through those. So we want to frame that as more positive.
So in terms of changing the narrative at AWP, what does that look like for us?
So it's really, really important. And as I said, I'm really, really passionate about that. So I provide an awful lot of training and guidance and reflective spaces for our staff to learn around suicide prevention and to have spaces to reflect. And we use sections on language. We know that the language that we use can guide our thoughts and then our actions. And so it's really, really important that we change our language to reduce stigma and encourage help seeking, because suicide is preventable with the right support. And we need people to come forward and seek that support in order to prevent as many suicides as we possibly can. So I just think it's really, really important. And particularly phrases like it's a cry for help can diminish the distress that a person is experiencing. So we need to shift that language and use terms like someone's connection seeking as opposed to help seeking or attention seeking. And language can create safety and can help with validation and creating those safe spaces to have conversations about suicide. So it's really, really important that we do change the narrative and that we do use less stigmatizing, more caring language around suicide and suicide prevention.
What I've noticed in my role is how courageous people are about talking about their own experiences, whether it's themselves or their families, and how important is it for you, both in terms of changing the narrative, but also the strategy overall that you feel can engage with people who are in that situation, have got that experience?
Absolutely. It takes great courage to open up that conversation. And I know, from a personal perspective, I'm also, I'm a mental health nurse, I'm a human being as well. I know that it would be very, very difficult to have those conversations. And that's why it's really important that we do think about the language and reducing stigma and encourage help seeking, because it can be preventable with the right language, with the right support, with the right care. And so I would encourage anybody who is experiencing suicidal thoughts to have that conversation, encourage our staff to show concern around that, to show care around people experiencing suicidal thoughts, because actually having a conversation, or for some people it might be the first time that they've spoken about the thoughts that they're experiencing, and depending on how that conversation goes, we can end up in a situation whereby people can feel more comfortable to be open with us about the thoughts and feelings that they're having. But if we get that wrong, then people might close down and not feel safe to have those conversations. And that's been a lot of the language has been driven by talking to people with lived experience and understanding how that really feels, and how language can either help people share what they're experiencing or not.
We know there are certain members or groups in our communities that are perhaps at a higher risk, so it's men of a certain age, but also autistic people and people that are not neurodivergent individuals. We know again are at a higher risk. How do we recognise the signs, and how do we sort of plan our support around those people?
Yeah, I think, Gary, this takes, a whole community effort. We've all got a part to play in this. I mean, mental health services play a significant part in suicide prevention. There are many reasons why somebody might be considering ending their life by suicide that are related to mental health. There are many things that can contribute to somebody having those thoughts, from social problems, psychological problems, living with chronic pain. You mentioned neurodivergence there, which is a particular group of people that we in AWP support and are very keen to support. We know that autistic people may be at greater risk of suicide, and we know that we need to adapt our approach accordingly. And so for that reason, we have worked with our specialist autism colleagues within AWP to produce some quite brief guidance for our staff on how they need to adapt the language. So asking more direct questions, being quite explicit in the way we talk about and adapting safety plans accordingly. We've got a trust-wide suicide prevention group in AWP, and we have people in that group that have got lived experience. And one person in particular has got lived experience of being autistic and experiencing suicidal thoughts. And they are a very respected member of our suicide prevention group. And we've also got the Kingfisher unit opening within AWP. So myself and my colleague with lived experience are supporting them with some bespoke training around safety assessments and suicide prevention, specifically for autistic people. But it's really important as well to think about how people might express thoughts differently. So autistic people may not show the classic signs.
Do you have any sort of key tips or tools for having those conversations if you're a member of the public that doesn't work in mental health services? How do you start that conversation with somebody you're concerned about?
Yeah, that's a really good question, Gary. And I think that it's single-handedly the most important question that we can all ask ourselves is, how do we respond if we are concerned about somebody, whether we be a specialist mental health worker or whether that be a friend or a colleague or a family member? I'd say that the most important thing to do is to ask the question. There has been a myth around that, what if I ask and it puts the idea in someone's head? There's an awful lot of evidence that tells us that that's not the case. By asking somebody the question, are you thinking about suicide, gives that person permission to tell you how they feel. And by not asking the question, we might communicate that we don't want to know the answer to that. So it's about asking the question with compassion, being curious, showing care and compassion around asking that question. And then what do we do if somebody tells us they are experiencing suicidal thoughts? I think that's often a great fear for people. And I certainly remember back in my early days of nursing, if I talked to somebody about suicide, I'd be kind of overwhelmed with this need to fix what the person was going through. And in working with people with lived experience, they've said loud and clear, we don't always need somebody to fix what we're going through. We need somebody to listen without judgment. We can provide reassurance that people aren't alone, that there is help out there and people don't have to do this alone. So I think the key takeaways are really ask the question, show care and concern and compassion, be curious about what's happening for that person, reassure them that they're not alone, and support them to get help.
That's really clear advice there, hopefully. And we talked a bit about the AWP approach to suicide prevention, the strategies that we're working through. But obviously, there's a national focus on this as well. How's AWP contributing to the Staying Safe strategy, isn't it? How's AWP contributing to that work?
Thanks, Gary. That's been a huge piece of work actually over the last couple of years. So in around September 2022, NICE produced some new guidelines around prevention and management of self-harm. And obviously as a mental health trust, we were looking at that guidance, thinking about how we were going to implement that guidance. That guidance gave some really clear direction around moving away from what we call global risk stratification, so rating suicide risk as low, medium or high, and making decisions about treatment or discharge based on those risk ratings. So an awful lot of evidence has told us that that approach doesn't work and it's not helpful for people. So we set about changing our approach to risk assessment, as it was called. And one of the very first things that we did, and the most important step, and I cannot say this enough, was about engaging with people with lived experience. We met with many people that had different experiences around suicide and suicidality. So people that experienced suicidal thoughts, received support from our services, and family and carers that have supported suicidal loved ones. And they told us overwhelmingly that they want to be involved in that process. They want to have those open conversations about suicide and safety. But something that was really key and kind of changed everything was people told us that the very language risk assessment can make people feel stigmatized. And I went away again reflecting on just being a human being as well, and thought about how I would feel if I was subject to that process, and it really kind of landed. So we made a suggestion following our co-production groups around changing the language of the very process from risk assessment to safety assessment, and our service users said that actually just that single word change made that process feel more caring, less stigmatizing, less labeling, less judgmental. And so we changed our approach in AWP, and that's been embedded now for the last about a year and a half. We've been using that. And following us changing our approach, we were involved in the writing of new national guidance, Staying Safe from Suicide, from NHS England. I personally was involved in the writing group and very much focused on the elements around language. I was completely inspired by a suicide prevention campaigner, a national suicide prevention campaigner, who he himself had lost his son to suicide, and was also very passionate about the language. So following that, the language that our service users, our carers in AWP said that was most helpful has now made its way into national guidance. And I want to be really clear that it's so much more than a word change. It's so much more than a word change. That language shapes everything, and in order to have a very personalised assessment of safety from suicide, we need to have those open conversations with our service users. And we can't start from a place of somebody feeling stigmatised when we talk about risk.
No, it definitely feels like a positive, shift into that, and you say a more safety focused conversation, which feels important. Just a final one on language for me, if that's okay, which is that balance, isn't it, I guess, between absolutely ensuring that the language is right, but also that people feel, as you said at the start, really confident and comfortable to have those conversations without fear of saying the wrong thing sometimes. So I guess there is that balance, isn't there, that we need to give.
Yeah, that's such a good question. And I was thinking about that aspect actually as I was talking, because we certainly wouldn't want people to be so concerned about using the right words that they're not comfortable having the conversation. So a little tip that I use for myself, I've been in mental health quite a long time. Some of these phrases like commit suicide or, unsuccessful suicide attempt have been around for a long time. So I sometimes say the wrong thing, and all I do is simply correct myself out loud and try and do better next time. So what I would urge people to do is try and use the right language, to think about the impact of language, But don't worry if you get it wrong. It's much better to have that conversation and say the wrong words than to not have the conversation at all and leave somebody feeling alone and unsupported.
That's great, thanks. That's really great advice. Again, and just to wrap up this session, then, is there any particular final messages that you'd like to give to people who have supported you as well?
Absolutely. And I made some notes around this, Gary, if that's okay, because I wanted to make sure that these messages were heard. So I just wanted to start by saying a massive thank you to the people with lived experience that so generously and courageously share their experience to help others who may be experiencing suicidality. Families and carers, the people who are so often doing everything they can behind the scenes to support someone in crisis, their role is incredibly challenging, and it can come with feelings of helplessness, fear, and even guilt. And I want to recognise their strength, the love, and the emotional toll it can take on them. We talked a lot about changing the narrative, and I personally believe that changing the narrative also means including families and carers in conversations about suicide, not just as caregivers, but as people who need support too. They deserve access to resources, to guidance and spaces where they can talk openly about their experiences. And importantly, they also need to feel that they're not alone in trying to keep their loved ones safe. And finally, to our nurses, psychiatrists and allied health professionals, a big thank you. Supporting people in crisis is emotionally demanding. It takes strength, it takes resilience, and it takes compassion. And sitting alongside someone in their most vulnerable moments, helping them feel safe when life feels unbearable, it's often quiet and compassionate work that goes unnoticed, but it's really life-saving.